Injury is the number one cause of death in people below 40 years of age and results in the highest number of years of life lost. When someone suffers from a traumatic injury, different clinician teams need to be involved in providing the patient with optimal care. Coordinating different teams in different locations who have different responsibilities is challenging. Even a slight delay in sharing information between teams can severely impact a patient's outcome. This hypothetical walkthrough highlights different teams and their communication practices in a typical trauma incident within the current system. A 30-year-old male falls from a building and a bystander makes a 911 call. Paramedics arrive after 15 minutes and perform a preliminary assessment. Finding that he's responsive and his vitals are normal, the paramedics transfer the patient into the ambulance where a more thorough evaluation and preliminary interventions are performed. 5 minutes after arriving on scene, the ambulance starts driving towards Vancouver General Hospital. During the trip, the paramedic in the back of the ambulance monitors the patient while making a phone call to the charge nurse at the receiving hospital. The paramedic reports the patient's stable condition to the charge nurse, who decides not to call for a trauma activation as he only meets one of two criteria. Minutes after the call, the patient's vitals decline and he becomes unconscious. The paramedic needs to perform resuscitation maneuvers for 5 minutes before being able to call the charge nurse to update them on the rapidly declined state of the patient. The nurse then calls for a trauma activation. The trauma team receives a message and gathers in the trauma bay only 3 minutes before the ambulance arrives at the hospital. Shortly after arriving at the trauma bay, the patient dies due to internal bleeding while the trauma team is still preparing for a blood transfusion. By interviewing and surveying personnel involved in trauma care, we identified 4 of the biggest issues with pre-hospital communication during trauma cases. First, making an audio call is disruptive to paramedics' workflow. Second, communicating a patient's condition in detail and with context is difficult. Third, the receiving hospital has limited time to allocate equipment and personnel for the patient. And fourth, the charge nurse and trauma team have limited information about the patient when they arrive. To address these problems, we set out to design a labor-saving system that could facilitate early and rich communication between the charge nurse at the hospital and inbound paramedics. With this design, we intend to improve patient outcomes, trauma team activation time, resource allocation, and reduce healthcare costs. We conducted site visits, interviews, and surveys with paramedics, nurses, and trauma team members, and developed a low-fidelity prototype based on our findings. Our system is designed to collect and transmit necessary information for timely trauma team activation, facilitate communication between paramedic and charge nurse, provide ways to support hands-free communication when patient severity increases, and provide a solution that is the least disruptive to current workflow. Here's how this system might be used in a trauma case like the one we described earlier. The paramedic picks up the patient who has fallen from a building and finds that his condition is stable. They can optionally use our virtual trauma bay tablet application to enter basic information about the patient and his injury. This information can be accessed by the charge nurse and other personnel at Vancouver General Hospital. When the patient's vitals drop, the paramedic can press a single button to indicate that its condition has become critical. From this point on, the paramedic won't have to touch the tablet again or use a phone for the rest of the trip and can keep both hands free for resuscitating the patient. This update will call the charge nurse at the hospital. From their application, the nurse can see the ETA and any patient information that has been entered for inbound ambulances. When this particular patient's condition is marked as critical, the charge nurse is prompted to answer a call. The nurse initiates the call and can view a video stream of the patient recorded by a ceiling-mounted camera inside the ambulance. They speak to the paramedic to learn more about the patient's status and decide to initiate a trauma team activation. To do this, the nurse presses a button in the virtual trauma bay app that automatically redirects the call to VGH's internal emergency line. Because the charge nurse was notified before the paramedic finished resuscitation, this system allows the trauma team to become activated about 5 minutes earlier than they were in the previous walkthrough, when a conventional phone call was used. The video stream and recorded information also give the charge nurse a richer and more immediate understanding of the patient's condition. With the virtual trauma-based system, we hope to facilitate pre-hospital communication between paramedics and charge nurses to allow early trauma team activation and increase the available preparation time of the receiving hospital. Early feedback from paramedics has indicated that this would be a valuable improvement to the trauma care process, but user testing will be needed to assess the value of specific features and the system's compatibility with paramedic and charge nurse workflows.